Welcome again, guys. So today will be serology part one. So as we discussed about our case, which is a 28-year-old woman who was born in the United States, but remember, she comes from, her parents actually come from an area that is endemic for hepatitis B, more than 8% prevalence in Taiwan. And she emigrated when she was, her parents emigrated 2 years before her birth, right? And the patient met her primary doctor. She was discussing about the family planning. Initially, she was resisting, but eventually she consents to get screened for hepatitis B. Remember, she also had family history of HCC in one of her maternal uncles. And therefore, again, this kind of is the context where we can talk about hepatitis B and how we can not only diagnose hepatitis B in her, but also prevent the hepatitis B transmission to her offspring. So we know that we need to get started with the screening. What test do you order? So this is kind of like a take-home slide for understanding the hepatitis B serologies. Even in my clinic, I do get primary care physicians ordering all different types of tests, including e-antigen, e-antibody, and again, not knowing what's the right test to do. So to start off, to screen for hepatitis B, we should know if the patient has hepatitis B surface antigen. Surface antigen positivity is a marker for active infection of hepatitis B. How do you define chronic hepatitis B? The presence of surface antigen for more than 6 months, okay? You don't need DNA, you don't need anything else. Just the presence of hepatitis B surface antigen for more than 6 months is by definition chronic hepatitis B, okay? Now we ordered that, then following that, we need 2 other tests. One of them is hepatitis B surface antibody or anti-HBsAg, okay? Now, surface antibody is the host response to hepatitis B, right? So if the antibody is positive, this means that the patient is immune to hepatitis B. Now, you can develop surface hepatitis B surface antibody for 2 reasons. One, either the patient got previously exposed to hepatitis B, or if the patient got vaccinated, and you know, all of you did a great job in vaccinating a susceptible individual. So how do you differentiate between one who got exposed and one who got the vaccination? So that is why we have the 3rd test, which is the anti-HBc. So this is hepatitis B core antibody, but this is an IgG test, okay? So again, this historically is a very good test to understand whether the patient has been previously infected with hepatitis B, okay? And very rarely, if you're seeing a patient with acutely elevated liver enzymes, this can happen in patients who have high-risk behaviors, either IV drug use, you know, exposure with contaminated needles, homosexual men. You would then test for IgM, part of the anti-HBc. And if that is positive, it typically is positive in the presence of acute HBV. But in a patient like our patient, Miss UN, all you need to do is the first 3, okay? So surface antigen, surface antibody, and core antibody. Step 2, if the patient is positive for surface antigen, okay, again, this means that the patient has active virus. Only in that scenario, you would do the following test, which is an e-antigen test. E-antigen classically stands for the envelope antigen and is a very good marker of what kind of hepatitis B the patient has. If a patient has e-antigen positivity, this means that most of the time the patient has the wild type of virus. You can see individuals, you can see patients where the e-antigen can be negative. E-antigen negativity typically is present in patients who have pre-core or basal core promoter mutations, okay? So again, when you're dealing with a mutant virus, and this can happen over a period of time where the patient has e-antigen positive virus, And during the natural course, the body develops antibody to the e antigen and then can convert into a mutant virus. Okay, so this can happen due to medications. This can happen along the course of the infection, or this can happen due to immune pressure. Okay, so a patient can start with e antigen negative disease and remain e antigen negative throughout their life. The presence of e antibody. So again, it is very important to know how the patient started. What was the initial e antigen status? If the patient started with e antigen and then turned positive to e antibody, that's a good seroconversion of e antigen. Now, if the viral load is also undetectable, that means the patient has achieved seroconversion of envelope antigen, and in a few cases, we can even stop therapy. If the patient started with e antigen negative disease, and when patients have e antigen negative disease, they're typically positive for e antibody. And if the virus is still present, then you need to continue to treat their hepatitis B. Okay, so again, you test for e antigen, and e antibody after you test for the surface antigen. Now, the marker of active viral replication is clearly the hepatitis B DNA. Okay, so a positive virus typically tells you that the virus is actively replicating. A negative virus, in the presence of the prior hepatitis B serologies, we can then decide whether the virus is active or not. So again, to go over the serologies and how do we interpret the serologies. Okay, so let's talk about the first scenario. All three tests that you saw on step 1, which is surface antigen, surface antibody, and core antibody, all three are negative. This is a patient who is susceptible to hepatitis B, right? So if a patient is in the endemic area of the world or intermediately endemic area of the world, these patients are at risk to get exposed to hepatitis B, and you need to vaccinate them. In the developed parts of the world, if they have HIV, if they're dialysis patients, if they're homosexual men, if they're drug users, if they have prior history of sexually transmitted illnesses, this is again a high-risk group, and these are the kind of patients where you would consider vaccinating them when they present with these with those symptoms and with those presentations. Now, if they're susceptible, and again, you're seeing a patient who is elderly, who is more than 70 years of age, healthy monogamous relation, you basically assess the risk of her getting hepatitis B in the United States, and you can have a discussion that if the patient is agreeable to get vaccinated. Again, in my clinic typically treats patients who have other chronic liver diseases. So again, when they have other chronic liver diseases like hepatitis C or fatty liver or cirrhosis, you don't want a second infection happening to them like hepatitis B. And therefore, I actually screen, and if they're susceptible, they get vaccinations for hepatitis A and hepatitis B. Okay, so every susceptible individual you should have a discussion about vaccination. And again, remember, hepatitis B, we talk about indefinite or lifelong treatments, right? But it is also very important to know that hepatitis B is a completely vaccine preventable disease. So you offer the vaccination, patient gets antibody positive, and they can remain immune the rest of their lives. Second scenario. So in this scenario, hepatitis B surface antigen is negative, hepatitis B core antibody is positive, and hepatitis B surface antibody is positive. Okay, so how you interpret these results is core antibody. Remember, it is a very reliable marker of a past infection, right? So that tells you that the patient has been exposed to hepatitis B in the past. Hepatitis B surface antibody being positive tells you that he or she developed immunity to a prior infection, right? And not having surface antigen is a good thing, and this patient can be monitored because she has protection to the hepatitis B. Now, only scenario that you need to be careful is when they're going on profound immunosuppression, especially with depleting agents like rituximab. What can happen is if the patient goes on treatment with rituximab for lymphoma or for other rheumatologic illnesses that require rituximab, it basically depletes the B cells, which produces the antibody. So the hepatitis B surface antibody, which is positive, can become negative, and the patient can seroreverse and develop surface antigen. Okay, so only in those cases you actually give antiviral prophylaxis. Going into the third scenario, this is the third box on the slide. Hepatitis B surface antigen is negative, hepatitis B core antibody is negative, and hepatitis B surface antibody is positive. So this, whenever I see this, I actually congratulate the primary care physicians because they've done a good job. They have identified someone who is susceptible to hepatitis B. So this is a classic patient like from the box 1. Okay, you do the first step. If all are negative, you vaccinate with 3 series of vaccinations. It's 0, 1, and 6 months. And if the patient has followed all 3 series of vaccination, he or she will turn positive to hepatitis B surface antibody. So this is really a good news that the patient is immune to hepatitis B and will not get hepatitis B in the future. And again, most healthcare providers, so all of you in the audience, also should have been vaccinated for hepatitis B. So if you check your status, you all should be in the third box, okay, which is surface antigen negative, core antibody negative, and surface antibody positive. Now, continuation of hepatitis B serologies. This is where it becomes more and more interesting, okay? So here, the patient has surface antigen positive. When you check for hepatitis B core antibody, it typically is a total antibody, which is IgG, and that is positive. You only check for IgM in the setting of acutely elevated liver enzymes, okay? So in this case, IgM is also positive, and you can see that hepatitis B surface antibody, which is a protective antibody, is negative. So this is a classic scenario where the patient is acutely infected. If any of your healthcare workers and colleagues get exposed to, to needles, contaminated needles, or during surgery, they get exposed to hepatitis B, this is how they will present. Okay, so they'll have elevated liver enzymes, and you'll see that surface antigen and IgM core will be elevated. Now talking about the fifth box, this is surface antigen is positive, core antibody is positive. Now typically you don't need to check for IgM, hepatitis B core antibody, but surface antibody is also negative. So this is a patient who is chronically infected, okay? So again, remember the definition of chronic hepatitis B, surface antigen positive for more than 6 months, that's it. Now the last scenario is also one of the most commonest scenarios that I encounter in my clinic population. So this is almost all the serology. Surface antigen is negative, surface antibody is negative, and core antibody is the one that is positive. So there are clearly 4 possibilities, and it's really hard to distinguish one from another, okay? All you see is the presence of core antibody. Now remember, I told you that a core antibody is a very reliable marker of a past infection. So in majority of the times, that's what it tells us, that the patient at some point was infected with hepatitis B. There is another possibility that the patient has a false positive hepatitis B core antibody, and this happens in approximately less than 15% of the cases. Okay, you can have a false positive, and this kind of reaction can be seen in patients who have other autoimmune conditions, okay, like rheumatologic conditions, Sometimes this can happen after they get vaccination for flu shot. Your immunity is so robust, you produce a lot of non-specific antibodies, and one of them can be a core antibody. A third possibility is a low level of chronic infection. Okay, this again, we don't know if this is a chronic infection unless you check for a DNA in the blood or you check for DNA in the liver biopsy. So an occult infection, which is so low, can actually make your surface antigen negative. Okay, this is not a very common scenario, so you typically don't have to work it at the primary care level. But if you still suspect it, send them to a hepatologist or check a DNA level in the next set of labs. The last thing will be in a resolving acute infection. So this is what we call a window period, meaning a person is acutely infected, and as they are about to clear the virus, remember, all adults or all immunocompetent adults, if they get exposed to hepatitis B, 90% of them clear the virus, right? So during the clearance phase, before they develop surface antibody, well, this is the only thing that is positive. Okay, so immunity is so robust that it cleared off the surface antigen, but it has not formed enough antibody that can be measured in the blood. So again, in these scenarios, just check for hepatitis B surface antibody again in 6 months, and by the time those patients will show up, will declare themselves whether they got the antibody. So far, so good. So again, these are the serology aspects of hepatitis B, which can be confusing. Okay, so when we look for other hepatitis B markers, remember we already talked about the viral markers, which are on the first box. The second box tells us about how the liver is doing. So two simple ways of knowing how the liver is doing. One is biochemical parameters. Obviously, we're going to check for serum liver function tests or LFTs, of which ALT is very specific for hepatitis B mediated liver injury. Okay, so that will tell if the liver is inflamed or not. Second is fibrosis markers. Again, in the absence of clinical stigmata for cirrhosis, meaning there is muscle wasting, there is ascites, there is jaundice, phytoangiomata, one will not know if the patient has additional or excess risk for fibrosis. Okay, we can clinically diagnose whether the patient is cirrhotic, but we wouldn't know if they have advanced fibrosis. So for fibrosis markers, back in the day, liver biopsy was the only way until 2011 or so, but now we have several non-invasive markers. So these non-invasive markers for fibrosis can be done either through elastography. So you have ultrasound-based elastography, you have MR-based elastography, and you also have shear wave elastography. So depending on where you work, you can figure out which one of these elastography tests you have access to. The other thing is, let's say you don't have any elastography scans or methods, you can actually check all these fibrosis markers using a blood test. Okay, a simple fibro test is good enough. We can even plug in the numbers for APRI. This is AST over platelet ratio. And you can basically calculate what the fibrosis of a patient is depending on those tests. Okay, so again, a fibrosis assessment is also going to tell you whether the patient is stable or the patient has excess fibrosis. So this is another important slide to kind of understand what happens when a patient gets hepatitis B. So these are the four classic clinical phases of hepatitis B. So in the first phase, you can see in the bottom, this is called immune tolerant phase. So in this phase, what happens is the patient's ALT, this is liver enzymes, are normal, and hepatitis B DNA is very high. It kind of is a name which you can understand just by the name. It's immune tolerant, meaning the patient's immunity is tolerating a high virus, and that's why the ALT is normal. The opposite end of the spectrum is reactivation. Okay, so in this scenario, you can see that this typically happens in e antigen negative patients. And what it means is DNA has been low and ALT has been low, but all of a sudden, both of them start to spike. And reactivation can occur in the natural course. So especially this can happen when a pregnant woman delivers the child, and then the patient gets immune reconstitution. This can happen when a patient who is on negative DNA and negative normal ALT goes on chemotherapy or immunosuppressive therapies. So in those scenarios, the virus, which is dormant, can suddenly reactivate and give rise to hepatitis. The next phase is inactive carrier. So this is a phase where ALT is low and DNA is low. And when we say low for ALT, men less than 30 is normal, and women less than 19 is normal. Okay, so again, whenever I say low ALT, it has to be below that threshold level. And hepatitis B DNA, we typically want the DNA to be less than 2,000 international units. Okay, so if both of them exist, we call it inactive carrier state. And then this is the phase where this is immune clearance or immune active phase, where ALT is up and DNA is also up. And basically all these levels can be fluctuating, as you can see on the graph. This is a typical scenario where you have to consider treating this patient with antivirals, because you want them to go from an immune clearance phase to an inactive carrier phase. Okay, and again, for reactivation, if you see reactivation, you should consider treatment. But if a patient is in the inactive carrier state going into immunosuppression, you have to think about prophylaxis with antivirals, because you don't want reactivation to occur in these patients. Okay, so again, wherever you see these elevations in the liver enzymes and DNA, you have to consider treating them. So there has been a little update in the nomenclature. These are the old terminology, as you can see here: the immune tolerant, immune clearance, inactive carrier, and reactivation. Whereas now the updated terminology is in immune tolerant stage. You basically call this as normal or just an infection. Whereas if you see ALT which is up, it's called hepatitis. Inactive carrier is also kind of a normal or an infection status. And reactivation, this is the stage where hepatitis B will cause progressive fibrosis. And if the patient is untreated, the patient can go into cirrhosis and liver cancer as well. So going into part 3, do we have any questions so far?
Can I ask a question? You didn't touch that level, but can I ask, how do I interpret hepatitis B surface antigen in a qualitative result? I'm sorry, not qualitative, quantitative.
So hepatitis B, that's a good question actually, okay? So hepatitis B surface antigen titers is not the routine yet, okay? If you have the ability to perform surface antigen titers, it's well and good. But the current recommendations are all to check for hepatitis B surface antigen, and if it is positive, you need to treat it as chronic hepatitis B.
Okay.
Okay.
I don't think
the reason for checking surface antigen titers, okay, remember the whole field is going towards, instead of indefinite therapy, can we find cure for hepatitis B, right? So what is cure? Cure means we need to eradicate hepatitis B cccDNA. Remember, as the hepatitis B infects the liver cell, it puts parts of its genome. It's called covalently closed circular DNA. It's called cccDNA in the liver cell. So whenever the liver cell multiplies, the hepatitis B multiplies. So in a patient who has DNA which is already suppressed, how do you measure if the patient is going to achieve cure or not? Well, the surface antigen titers are going to give us at least an estimate of how the cccDNA is doing. Okay, so it's a very good biomarker to estimate the activity of hepatitis B in an already suppressed, no DNA or undetectable DNA patient. Does it answer your question?
It is confusing still, but thank you very much for the answer. It gives me a lot of light.
Okay.
Because
it is not a test that needs to be routinely done.
Okay, and I've been getting it, you know, especially when the provider tests for STD screening testing, and then they don't know what to do with the results, and neither do I, because it is very, very new to me.
Right. The presence of positive surface antigen should actually alert you to treat that patient as chronic hepatitis B.
Wow.
Regardless of the titer, that should give you the alert that this patient has chronic hepatitis B.
Okay. Thank you so much.
Yeah. You measuring the surface antigen titers is actually a very good thing, but it is still in the investigational phase. Okay. So, for example, like I was trying to, I'm trying to be intentionally redundant here. So, if you already treated the patient and you've put the patient on antiviral therapy, the patient's DNA is completely undetectable, right? Now you want to know whether the hepatitis B, is the patient going to clear hepatitis B or not, right? Because there's no other marker. DNA is already undetectable. Then you can use surface antigen titer as a way to figure, can you cure this patient or not? Okay.
Okay. Actually, this patient is also co-infected with Hep C. So apparently, the patient is going to be treated, and that was the purpose for the hepatitis panel to be run.
Right.
So in this case, the patient will be treated for both hepatitis B and hepatitis C?
Yes. So so in patients with hepatitis C, remember, hepatitis C is completely curable, right?
Yes.
So when you treat hepatitis C with the currently available direct-acting antivirals, it's a finite course of treatment, right? The shortest duration is 8 weeks. The longest can be up to 12 weeks. So 2 to 3 months of treatment.
Okay.
But all direct-acting antivirals have a black box warning in them, because if you treat hepatitis C, the underlying hepatitis B, which is dormant, can actually reactivate. Okay, so it is imperative that you have to treat hepatitis B first, control the virus, and then embark on hepatitis C treatment. So during the hepatitis C treatment, you're not going to have a reactivation of hepatitis B.
Thank you so much.
Sure. But great questions.
Thank you.
Any other questions, case presentations?
Any other questions? Everyone should be unmuted unless you need to unmute yourself. No? All right, in that case, we're going to move on to the case presentation, which Jason will be presenting for everyone. Oh, I'm sorry. Dr. Smiley, did you have a question?
Yeah, can you hear me?
Yes, we can.
Yeah, I was a little confused about E antigen negative patient. How do you know if this person is a pre-core mutant or if they're starting to actively seroconvert from E antigen to E antibody, from E antigen positive to E antigen negative, but the E antibody hasn't risen yet?
So whenever you see a patient for the first time, That's why we need to, when you do the initial testing, you need to have e antigen and e antibody tests in a patient who already has surface antigen, right? That part was understandable?
Yes, but sometimes, you know, I'm seeing somebody who was from Vietnam and they, who knows how long ago they've been infected. They could have been infected 30 years ago.
Right. So if you look at the classic textbook teaching, e antigen positive patients are the ones who are highly contagious, right? So e antigen positive patients will typically have viral loads over 5 logs. This will be in millions. And therefore, again, we didn't go into the treatment aspects of hepatitis B. What typically is recommended is in e antigen positive patients, you start treating them when the DNA level is over 20,000. Whereas in e antigen negative patients, these are the mutant patients, you actually treat them when the DNA is more than 2,000 international units, right? So again, when you look at a patient with e antigen positive or e antigen negative, yes, initially it looks kind of confusing, but if the patient really seroconverted from e antigen to e antibody, you would expect the DNA to be almost undetectable, okay? Whereas if a patient already has e antigen negative disease from the beginning and he got infected from a mutant virus, vertically transmitted or sexually transmitted, the e antigen negative virus remains e antigen negative. So you will see some amount of virus positive in that patient. Okay, so it's really, to understand the natural history, you need to kind of get the reports from the initial time they got the panel done. Otherwise, you just have to kind of conjecture, guess based on the available information.
I had one other quick question.
Sure.
I had a co-infected hepatitis B and C patient.
Okay.
Surface antigen was positive. This person, I did not pre-treat for hepatitis B. I started treating hep C and monitored his HBV DNA, which was initially undetectable. So the surface antigen was positive, HBV DNA was undetectable. And it started to rise a little bit over the first 4 to 8 weeks, but it never rose about 900, not 9,000, but 900. And then at the completion of hep C, it dropped. So I did not pre-treat for hep B. Was that a mistake, or do you think I should have treated him for hep B first before starting hep C?
Yeah, it is one of the fortunate cases that didn't have a flare-up, okay? But when you look at the FDA reports, and this was all during the clinical phases of the direct-acting antivirals, there was a lot of data presented from Decladisvir and from Asian patients especially who were co-infected, that the presence of surface antigen is the one that actually can lead to a severe reactivation. And up to 10% of them actually had to undergo a liver transplant or they succumbed to hepatitis B flare. Okay, so again, when you look at the percentage, it's 10% who will have a very severe flare. 90% will do okay. But when you look at actual numbers, 1 out of 9 patients can die. So I think if you see a surface antigen positive patient and is co-infected with hep C, you need to prophylax them. But it is good thing that you actually monitored this patient very closely. So again, should the patient have reactivated, you would have noticed right away. But again, in order to prevent a severe flare, the FDA basically recommends that hepatitis B needs to be treated along with hep C.
How long would you continue the hepatitis B treatment for after eradication of the hepatitis C?
Yeah, so again, I think this will be, so in a chemotherapy world, okay, you actually need to, this is called prophylaxis. You're not really treating hepatitis B, you're preventing a reactivation, right? So in chemotherapy world, what we do is we start 2 weeks prior to the chemotherapy, they continue the chemotherapy, and we continue for up to an year after they finish the chemotherapy. So you can use kind of similar rules, but this is an extrapolation in a Hep C co-infected patient. What I do in real world is if the patient doesn't have any contraindications, and we know that hepatitis B is a carcinogenic virus, I would actually have a discussion with the patient and talk to him about indefinite therapy. And, you know, the patient already has Hep C, so he kind of has two viruses. If you do a FibroScan, if the FibroScan shows that there is significant fibrosis, which is F2 or more, again, that would make a case for indefinite treatment. If the patient has really, really early fibrosis, like F0 to 1, you can probably talk to the patient. Listen, I'm going to give you from 2 weeks prior to the DAA therapy up to 1 year, and then we can trial, we can stop, but you need to be closely monitored. If the patient is agreeable for that kind of close monitoring and stopping therapy, I think at 1 year you can stop the prophylaxis.
Speaking of prophylaxis, I was referred a patient who was getting rituximab for a lymphoma, and his serologies were hepatitis B core antibody positive, but surface antigen negative, surface antibody negative. And I elected to prophylax this patient. Do you agree with that, or do you think unnecessary?
You did absolutely the right thing. Okay, so isolated core antibody, especially if they're getting intense immunosuppression, like a B cell depletion therapy, they need to have antiviral prophylaxis. Okay, and it kind of, there are several reports. There is evidence behind seroreversion of isolated core antibody, and it doesn't have to end up in liver failure. Okay, but actually this did happen to one of our trauma surgeons who was core antibody positive, which was not checked during the time of lymphoma therapy, and he eventually succumbed to hepatitis B flare. But what can also happen is if they have an icteric flare, okay, so let's say this is not, they don't end up in acute liver failure, but it would cause their liver test to go up to 600, a bilirubin of up to 5 or 10. Remember, these anti-neoplastic therapies need to be stopped, and then their lymphoma would progress, right? So why do you want to take a risk of not prophylaxing them and let these kind of severe reactivations occur? So I completely agree with you, and you did the right thing in giving them antivirals.
Thank you. I actually had a couple of people questioning me, why are you doing that? Oh. And I gave him the same answer you did, and he did well. But I did not continue for a whole year. I just continued his anti-hepatitis B prophylaxis for like 6 months, I think. It was after completion of chemotherapy. It probably should have gone longer. Yeah.
No, this is actually a chronic discussion that we used to have. This was back when I was a fellow, and the ASCO, which is the American Society for Oncology, they wouldn't put that in their guidelines about treating core antibody patients or screening for them, for that matter, even when they got rituximab. But thankfully, all of that has changed. So again, I don't know which sources you go to, but AASLD, this is American Association for Study of Liver Diseases. If you look at practice guidelines for hepatitis B, this is freely downloadable resource. You look and you can see that core antibody positive with rituximab therapy needs antiviral prophylaxis. So that's your evidence behind what you did.
Yes, thank you.
Sure. Any other questions, cases?
All right, in that case, I will share my screen so that Jason can present his case formally using one of our templates here. So give me just a moment. All righty, can you all see that?
Yes.
Wonderful. Alrighty, so Jason, you have the floor. Please feel free to go ahead and present your case.
Okay, so thanks. Just really quickly, this was a case, unfortunately, that we had just backed into the diagnosis of hepatitis B by accident. So it's a 76-year-old Tongan gentleman with diabetes and hypertension. He was actually undergoing a ultrasound for working up hematuria, microhematuria, and the ultrasound technician noticed a possible cirrhosis of his liver. We did follow that up with the ultrasound that confirmed already advanced cirrhosis, at which time we found 2 discrete lesions in his liver, and we drew the hepatitis serology that you can see probably on the next page. But basically, he had chronic hepatitis B infection. He actually had been coming to our clinic previously. We don't have a hepatitis B screening algorithm. And so sadly, his Hepi DNA, though, was pretty low, I guess. It was 17. And so we ended up transferring him to the county hospital. They did a CT scan, which showed 2 4 lesions probable for hepatocellular carcinoma. And he was eventually referred to our university hospital for transarterial chemoembolization of those lesions. I don't have all the information on the submission there because a lot of the care was obviously not done by us, but that's kind of what I got from the other centers. So, so we are now working on our hepatitis B screening algorithm, and hopefully we'll have that in place with the help of the ECHO seminars here.
Yeah. Thank you, Dr. Jason, for presenting this case. So I want to kind of highlight some of the points from a serologic perspective. This is what the focus for our module 2 is. So again, if you look at the serologic perspective, patient has core antibody positive, right? Surface antigen is positive, and surface antibody is negative. So in all regards, this patient has chronic hepatitis B, right? So if you look at the DNA level is quite low. It's 17 units only, right? So when you label this patient, again, is this chronic hep B or not? When I talk to my fellows, when I talk to some of my colleagues in the primary care, they would say, oh, the viral load is low. This is not a case of chronic hep B. Well, that's why this is important, that the definition of chronic hepatitis B is presence of surface antigen more than 6 months, regardless of DNA. The patient can have even less than 15 units, okay, because less than 15 is undetectable virus. Even if it is less than 15, presence of surface antigen tells you that this patient has active hepatitis B, okay? So again, like you mentioned, this is a sad case because most of these patients, until they present, they actually don't have any symptoms. And I do have one of my 38-year-old Haitian patient who also has exactly similar picture. This patient is 76, almost, lived most of his life. But think about a 38-year-old Haitian man with 4 kids. His primary doctor basically checked his LFTs, and you will see exactly the same kind of picture, which is AST/ALT in the 40s range, and therefore the screening was never offered because these are in the normal range. Okay, I want to highlight that for a man, anything over ALT over 30 is abnormal, and for a woman, ALT over 19 is abnormal. So again, this should kind of bring up the alert, the clinical alert, that he should be screened for chronic liver disease. One of the things again is platelets being low. Okay, so again, low platelets is a classic indicator of splenomegaly and portal hypertension. So again, when you see low platelets, think about hematologic issues, obviously, ITP, all those other chronic thrombocytopenic conditions, but also keep in mind that when you look at the liver enzymes, ALT being higher than normal, albumin should be over 4. So in his case, albumin is 3.4, which is low. So we should have a little high index of suspicion that something ominous is going on in this patient. And again, if the patient comes from endemic areas, a hepatitis B screen would have helped. And as we talked before, it causes cirrhosis and it causes cancer. And this patient has both, right? The next question, I want to save this exact case vignette for when we go to the future modules for whether you want to treat this patient or not. I don't want to reveal the suspense now, but I think for the purposes of this module, interpreting serologies and interpreting what this patient has is sufficient enough, if you all agree.
Thank you.
Yeah. Okay.
Okay, so if we have no other questions, thank you very much, Jason, for presenting your case.